Some of the things we'll touch on today are how to perform screening and diagnosis of obesity based on the current guidelines, which I think is really relevant for all of you in clinical practice. We're going to identify which patients are appropriate candidates for medical and surgical interventions for weight reduction. We'll go through some evidence-based lifestyle modification strategies, and we'll touch on some of the FDA-approved anti-obesity pharmacotherapy and their indications for use. So first, let's start with definitions and pathogenesis. So what is obesity? It is a highly prevalent, chronic, relapsing, remitting disease, but it's really characterized by the presence of excess fat mass. And I think the key is that what qualifies as excess or unhealthy is really different between one individual to the next. Somebody might have absolutely no metabolic consequences at a BMI of, say, 27, and then someone else has horrible metabolic disease at a BMI of 23. So we'll talk a little bit more about that later, but again, I really want you to get that in. If you take nothing else away from this lecture, it's really an individual variation from one person to the next. Obesity is associated with physiologic changes in appetite and metabolism regulation. This is a chronic disease, and it's strongly correlated with cardiometabolic risk. There are numerous factors that contribute to the development of obesity, including genetic factors, some things that we can't modify, but then there are plenty of behavioral and environmental and social factors that patients do have the opportunity, and we as clinicians have the opportunity to intervene upon. So I really like this slide because I think it highlights, kind of the underpinnings of obesity, the disease, which is that when our subcutaneous space, that's the healthy storage space underneath our skin where fat is really accumulated for energy storage, when that reaches the limits of its expandability, fat starts accumulating in other places. And so specifically places it shouldn't be, like viscera, heart, inside the liver, inside the pancreas and kidneys. And specifically when we have fat inside our liver and pancreas, that dramatically increases the risk for type 2 diabetes and metabolic disease. And so this illustration over here on the left is an old figure from National Geographic, but you can see, I'm not sure if you can see my pointer over here. This is a female who's 120 pounds compared with somebody who's 250 pounds. And you can see this kind of, gynecoid, healthy, hip distribution of fat. We have a normal sized liver. We have a heart that is not enlarged and not filled with fat. And over here on the left, you can see this individual not only has increased subcutaneous depots, right? It's sort of filled up as much as this person can handle. And then we now see deposition around the organs. We see an enlarged liver filled with fat. We see fat kind of surrounding the heart. And even over here, probably this person also has obstructive sleep apnea. So this is kind of that spectrum. And again, everyone's going to have their own genetic potential. Environmental things like smoking and alcohol use are going to modify how aggressively somebody stores fat in those organ spaces. But this is really the link between fat accumulation and inflammation and insulin resistance, which ultimately leads to metabolic dysfunction. So to summarize obesity as a disease, we have individuals gaining weight when we have a net positive caloric balance. That's that kind of in out, right? But not everybody gets to the point where we would call it obesity, the disease, right? So there's a subset of patients who gain weight to their own personal individual tipping point, right? And whatever that may be, we start to see expansion of visceral and subcutaneous and ectopic fat mass. And that is what leads to both mechanical stress. So we have excessive and pathologic physical forces that might cause joint strain, immobility. You might see mechanical compression symptoms like sleep apnea or acid reflux. And then you can see tissue friction. So we can see skin rashes, right? And intertrigo. I'm sure many of you have already seen this in your clinic. And then on the other hand, we see the deranged hormonal and immune response associated with obesity. OMA, the Obesity Medicine Association, likes to call this sick fat disease, but essentially adiposopathy is when you have enough fat in the ectopic spaces that it's inflammatory. It's secreting cytokines and other inflammatory factors into the bloodstream. And this results in elevated blood sugar, elevated blood pressure, lipid derangements, changes in appetite regulation, and a whole other spectrum of increased cardiometabolic risk. And the final thing I want to say about obesity pathogenesis is that it's very hard once obesity is established to actually, treat obesity and lose weight and keep it off, right? We have something called metabolic adaptation. So when somebody loses weight, say they lose 5 or 10% of their weight, the brain senses that loss of fat mass, and there are adaptations that happen because the genetics that we have thanks to our ancestors who had periods of famine, right, and feasting, is conservation. So whether or not you're at a increased fat mass state or not, that relative loss of fat mass is sensed as a stress. It's sensed as a periodic famine, right? So your brain goes, uh-oh, what happened to all that fat mass? I need to slow things down. And so we start to see changes in hormone sensitivity. We see loss of inhibitory control. So we know dopamine signaling is actually affected in obese individuals, excuse me. So they don't get the same reward from food that people who are not obese have. And so we also see slowing of the metabolic rate, changes in neuroendocrine response, changes in sympathetic tone, and a lot of downstream effects that ultimately make it very difficult to keep weight off. And this is where medical therapy and some more aggressive interventions can be helpful for our patients who are working against this physiology in the background. So let's talk about epidemiology and the rationale for treating obesity. So again, this probably comes as no surprise to most of you. We have dual epidemics of both diabetes and obesity happening in tandem. In our area of the country, it's particularly striking. About 70% of the adult population in the United States is overweight or obese. Here in the district, it's actually a little bit lower. We have a younger, more transient population here. But in Maryland, it's about almost 35% of residents as of 2021. And throughout the country, the numbers are staggering. And this, in turn, goes hand in hand with risk for diabetes onset. So the estimates are that about 11.6% of the adult population in the US actually has diabetes. And 60% of this disease risk is attributed directly to obesity. This is a tremendous burden on our healthcare system. When you look at the cost of obesity, it's estimated that this costs us every year $260 billion. And this is old statistics, right? The cost of caring for somebody with obesity is about 1.5 times greater than someone without obesity. And then again, this is linked to diabetes risk, which costs us over $400 billion a year in healthcare costs, both direct and indirect. And the cost of caring for a diabetic is over 2.5 times greater than somebody without diabetes. We do now have effective medical therapy, which I'll talk a little bit about later, but the cost of that is about $10,000 to $15,000 per year without insurance. And the cost of bariatric surgery is a one-time of about $15,000 to $30,000. So we keep these numbers in the back of our mind, but there is certainly a huge burden, and it really becomes important to intervene early and aggressively when we start to see these higher risk features in our patients. And again, it's really important because we know obesity increases the risk of death. The lowest mortality in this large meta-analysis of almost 1 million patients showed having a BMI in the 22 to 25 range had the lowest mortality. Once you got up to a BMI of 30, there was about 2 to 4 years of life reduced survival. And once BMI was above 40, which we'll talk about later, but that's the most severe class of obesity, it takes 8 to 10 years off of your life. But the good thing is that when we have intentional weight loss or more aggressive interventions like bariatric surgery, this is shown to have statistically meaningful reduction in mortality outcomes. And just to touch on that again, when we have obesity established, if you have the second hit of having diabetes on top of having obesity, your risk for certain mortality is incredibly higher. So for example, somebody who has obesity with diabetes, the risk of, say, cardiac or stroke death is about 3.5 times higher. And then if you look at the chronic kidney disease outcome, so your risk of dying from a kidney outcome actually is 20 times higher if you're an obese individual with diabetes than if you're obese and you don't have diabetes. So this is really a call for aggressive early primary prevention so that our patients don't become diabetic who are already at high risk, right? So primary prevention works. We have lots of evidence at this point. We have both, diet and lifestyle modification trials. So both within the US and outside of the US, the diabetes prevention program, are highly successful, somewhere in the order of like 40 to 58% diabetes risk reduction over about a 7-year period. We finally got, ad hoc data from semaglutide. So I'll talk to you a little bit about that later, but that's our most effective, or one of our most effective medical therapies that's approved. And when they went back and looked at the 10-year forward data, being on that drug and having significant weight reduction actually reduces your risk of diabetes by about 60%. And then when we look at bariatric surgery, again, the most aggressive intervention with regard to weight reduction, we start to see outcomes about 80% diabetes risk reduction. What you'll also notice is it's not 100%, right? So even the interventions we have are not foolproof. And a lot of that, when we look at failure rates for medical and surgical therapy, it has a lot to do with having, fat within the pancreas and within the liver. Folks who have that higher amount are the ones who fail the most, thinking back to that first slide that I showed you. And secondary prevention works as well. So this was an intensive lifestyle modification program that showed really high rates of type 2 diabetes remission if you could achieve a weight loss of at least 10% or more. So we always tell our patients, oh, lose 5%. But when you start to look at the data, you really need to hit these higher numbers of about 10 or 15%. But if you can see over here, so the baseline folks, these were diabetics who didn't have diabetes for that long, so less than 6 years duration. A1C was under 10. Average weight was about 92 kilograms. So if you lost 9.2 kilograms or greater, that was at least 10% of your weight. So you can see over here, folks who hit that target had a diabetes risk reduction of at least 60%. And those folks who lost about 15 kilograms, now we're talking about 70 to 85% risk reduction. So we're comparable now to bariatric surgery, right? But you have to lose a really aggressive amount. So depending on the person and their risk, we need to be thinking about these targets and how aggressive we want to be. And so you can see actually for every kilogram of weight that was lost, there was about a 1.3 odds ratio risk reduction of diabetes remission, excuse me. And the reason this also becomes important is we have data showing that when you don't hit that mark, you don't see comorbidity improvement. So I don't know if you're familiar with the Look Ahead trial. This is similar to DPP, but for people who already had diabetes. And it was asking the question, if we get people to lose a significant amount of weight, will that improve cardiovascular outcomes and morbidity long-term? And so they did a great job. They actually had an aggressive lifestyle intervention, and they achieved about an 8% weight loss on average at about 1 year after intervention. You can see that there wasn't a long-term maintenance of that, but relative to where they started, these folks are actually still achieving and maintaining a little bit of a weight reduction. And they followed these folks over a 10-year period, and this did not improve any outcomes. You can see A1C kind of trended back up over time. So this was not a sustained intervention. And ultimately, we didn't really see any benefit from this. So, the take home is that you have to have greater weight loss in order to see better benefits for folks who already have high-risk cardiometabolic disease, aka type 2 diabetes. And the reason this happens is because different obesity-related diseases improve at different weight loss thresholds. And so diabetes, again, it could be as little as 5%, but on average, what we know from bariatric studies and kind of more aggressive interventions is that really 10 to 15% is what's necessary, which is why it improves so much better after surgery. But even things like blood pressure, arthritis, sleep apnea, again, some of these things we need to hit about 10%. So that's the magic number I want you to have in your head when you're seeing somebody who has a comorbidity. You really don't want to be just getting a couple pounds. You want to be targeting 10% or more. And so again, on the spectrum, so small amounts of weight loss are good for things like glucose control and blood pressure control. But when you're talking about prevention of type 2 diabetes, you really need to be targeting upwards of 10%. Fatty liver. When we're talking about established liver disease or cardiovascular disease, you want to hit at least 10 to 15%. And for diabetes remission or cardiovascular mortality, it's really 15% or greater. Sorry, guys, my allergies are killing me right now. So overall, obesity management goals, once you identify an adult patient with overweight or obesity, the goal becomes to assess and then treat any underlying adipocyte tissue dysfunction and excess body fat with the ultimate goal to improve patient health, improve quality of life, and improve body weight and composition. And so how do we approach this in clinical practice? We always start with screening and diagnosis. So you want to start with anthropometric analysis, which we'll go over. You want to do a clinical assessment. So take a weight-focused history, do a physical exam, and then you want to assess for weight-related comorbidities because this is how you're going to stratify your patient. Next, you want to come up with a treatment plan. and take things into consideration that you've already screened your patient, right? Do they have any high-risk comorbidities like diabetes? And once you've kind of made that decision of what your weight loss target is, you want to enter into lifestyle modification, potentially pharmacotherapy, depending on how much weight you need to achieve and whether or not you're comfortable doing that management yourself. You might consider referral to a weight management specialist. And then potentially, depending on the patient, you might even consider bariatric surgery. And then you have to have a long-term plan because this is a chronic disease, right? So let's start with screening and diagnosis. So first way we always screen, and this is the most common and kind of tried and true way for screening, is the body mass index. So we define overweight as a body mass index of 25 or greater. Obesity is a body mass index of 30 or greater, and then severe or class 3 obesity is a body mass index of 40 or greater. This is a weight to height ratio. The nice thing about BMI is it's inexpensive, it's highly reproducible. The medical staff can get this number for you into the chart immediately. And this is an adequate screening tool for most patients and epidemiologic studies. However, BMI comes with caveats, right? This does not account for muscle mass or gender-specific differences in body composition. So women have higher body fat percentages than men, naturally. And again, somebody like, say, a bodybuilder, right? If you think of Arnold Schwarzenegger, who has a lot of muscle mass, body mass index is not necessarily going to accurately represent fitness or fatness. It also may not correlate with disease risk. We know there's some limitations that, again, gender and racial and ethnic variability at certain BMIs. So particularly for, African-American women, BMI actually overestimates risk. They're healthier up to a BMI of about 31 to 33, whereas other ethnic groups actually have higher comorbidities at lower BMIs. So depending on your patient, you may want to take some of those factors into account, and adjust your target overall. So just to highlight what I mean about gender-specific differences, you can see that BMI tracks very steadily with risk for type 2 diabetes, regardless of gender, right? So as we go up, once you hit a BMI of 30, rate starts to increase exponentially. Once you get to a BMI of 35 or greater, we have really quadrupled our risk, right? But you start to see that the rate of increase in women actually starts at a body mass index of 22, right? Whereas men, it starts at that classic cutoff of overweight of 25. And so our BMI standards were based off of white European men. That's when it was developed, right? Back, there was a Dutch scientist a long, long time ago. This was perpetuated again by MetLife insurance tables in the 1920s. And then it was furthered again by another white male in the 1950s. And so all of the standards, all of these are based off of kind of Eurocentric, body distributions, and may or may not reflect other populations and may not reflect risk. Where we kind of lump everybody into the same standards, but you really need to think, does this apply to my patient and how would I modify this going forward? And so there are guidelines geared towards Asian populations, particularly because there's a lot of evidence that BMI cutoffs do not approximate risk and health action points appropriately. If you look at standards for BMI in other countries that are being used, like in China and India, the recommended cutoff for overweight is actually a body mass index of 23, and the cutoff for obesity is a body mass index of 27.5. And so the reason for this, if you think again back to that first image, right, with our visceral fat, the fat inside the organs, at a given body mass index, Asian individuals tend to have more unfavorable body fat distribution and a higher body fat percentage. They have significantly more visceral fat, so that kind of high metabolically active fat. They have higher risk for cardiometabolic disease like diabetes at a lower BMI, right? And they also have less muscle mass and lower resting metabolic rate relative to other individuals. So we need to keep that in mind when we're, applying, again, Eurocentric standards to some of our patients, that we really need to modify those criteria and think and look at the numbers, and also look at, the labs that are maybe telling you, hey, my patient has a body mass index of 23, but they've already got evidence of hypertension and prediabetes. Maybe I should be more aggressive. So BMI is just a number. It really requires kind of validation and for you to assess the patient as a whole. There are other methods for defining obesity that sometimes we use in clinical practice, including waist circumference. So In the United States, men with a waist circumference over 40 inches or women with 35 inches are considered to have central obesity. Again, the standards in Asia are different. This applies to both South Asians and Pacific Islanders. So cutoff would be 35.5 for men and 31.5 for women. We use waist to hip ratio. So again, this is kind of looking at that apple versus pear distribution. So in men, waist to hip ratio over 0.9 is considered overweight and obese. Women, it's 0.8. And high risk, any gender, is if you have a waist to hip ratio over 1. And then a final method is body composition. There's lots of different ways to do that. You can use that, use a machine, you can use calipers, you can use underwater weighing. There's lots of different methods that we use both in research like DEXA scans. This tends to be more expensive, unreliable, and body composition is really felt to be expert opinion because again, right, everybody has their own individual threshold of what body fat percentage causes trouble in their body. And so we don't usually use that as a standard, but it's something that's helpful because sometimes patients will come in with reports or we'll use that information as well. So which is the best estimate of obesity? At a population level, BMI is going to be the most widely used. BMI, percent body fat, waist to hip ratio, and waist circumference all similarly correlate with risk for metabolic syndrome. But at an individual level, BMI is useful for screening, but again, it requires validation. Body fat percentage is a better indicator of obesity in individuals at extremes of muscle mass. So again, athletes or patients who are sarcopenic, so they have wasting. And if somebody has a body mass index below 35, waist circumference is actually the strongest predictor of cardiometabolic disease. I don't know how many of you have tape measures in your office or measuring waist circumferences routinely in practice, but it's something we probably don't do often enough. And then as far as clinical assessment, you want to help kind of, again, risk stratify your patient. So take a thorough obesity-focused medical history and medication review. You might ask questions about precipitating factors, behavioral contributors, stressors. You might want to assess support systems and things like socioeconomic and cultural factors and nutrition knowledge before you make guidance and recommendations to your patient who may or may not be able to comply with your advice. And then you want to ask open-ended questions in a non-judgmental way. Things like, what is hard for you to do at your weight? And then you want to take again, weight-focused review of systems, screen for sleep apnea, really high prevalence in individuals who are obese. Take a family history, do a physical, and then obtain any relevant lab studies. And then finally, you want to define obesity by assessing for weight-related complications, right? So this can be anything from mechanical to cardiovascular complications, reproductive issues. Diabetes would be the most common one we're going to be looking for, fatty liver disease, cancer, and then even mental health, things like low self-esteem and depression. So this is the final step in assessing your patient before you go to formulate a treatment plan. And so taking all those factors into account, there's several different guidelines that you can use, and I encourage you to take a peek at these if you ever have a chance. So the American Heart Association, American Cardiology College, and the Obesity Society put out guidelines in 2013 that emphasize using BMI to guide treatment, and focus on weight reduction. And then some of the other groups, like the ACE is one of the endocrine organizations, and then OMA is the Obesity Medicine Association. They emphasize comorbidities a little bit more aggressively, but at the end of the day, everybody is encouraging treatment, at a body mass index of 30 or greater, and then risk stratifying your patients depending on medical comorbidities. And so across the guidelines, recommendation is for anybody at risk to begin lifestyle interventions. This can be self-guided or this can be medically supervised. Typically with lifestyle interventions, we expect about a 1 to 8% weight loss. So depending on the patient, again, we talked about those targets, somebody might not need to hit that 10%, but depending on the comorbidities, that may or may not be enough in isolation to reach kind of medical goals for weight management. And then for medical therapy, the criteria that insurance are going to require is a body mass index of 27 or greater with at least one weight-related comorbidity. And you need to document this in the plan of your note. You need to document the BMI in order for insurance generally to cover these things. Again, with the caveat that for certain individuals, who are Asian or have an increased waist circumference, you may want to be advocating for them to have therapy a little earlier if they're at high risk. But with medical therapy, so I've used this slide for a really long time, and I finally got to update it because it used to say 3 to 10% for a really long time. And now we actually have effective medical therapy where meds are getting close to bariatric surgery. So now we have stuff that can cause 20% weight loss, which up until a few years ago was actually not possible with medical therapy. So I think we're at a really exciting time for weight management. We'll talk a little bit about some of those meds later. But depending again on the target, if you need to hit that 15% or greater reliably, you might be thinking about sending somebody to bariatric surgery. And so for medical therapy, if you have a body mass index of 30 or greater, you do not need to have a comorbidity. Anyone with 30 or greater is eligible. The same goes for bariatric surgery. Anyone at 35 or greater is eligible for bariatric surgery, regardless of comorbidities. But thinking about going down to a BMI as low as 27 or 30 if there's diabetes with inadequate glucose control. And so in the last 2 years, multiple different practice societies like the American Diabetes Association and ASMBS as the Medical Bariatric Society have all issued guidelines advocating for earlier bariatric surgery, particularly in uncontrolled diabetes. Currently, insurance and CMS do not necessarily reflect that. I think the last time they updated their paying guidelines was in 1990, if I'm not mistaken. Some of you may not have even been born yet in this room. So, again, we have to get with the times. I think there's a lot of data and a lot of guidelines that have been issued in the last couple of years that hopefully we're going to start to see coverage and better coverage for both medical therapy and surgical therapy. But for right now, if you're going to send a patient in general, they have to have a body mass index of 35 or greater with a comorbidity in order to qualify for bariatric surgery, even though the guidelines say they could get it earlier. Okay. So lifestyle modification. This can include anything from diet and nutrition therapy, physical activity, behavior changes, self-tracking of data, improving sleep habits, stress modification, smoking cessation. All of these things have been researched extensively and show positive benefit for weight management strategies long-term. But we get this question a lot. Doc, what is the best diet for weight loss? And so for short term, I'm just going to summarize like 50 years worth of data for you guys in one slide. But essentially, short-term evidence suggests that very low calorie, low carb, and ketogenic diets, this might include meal replacement plans, things like that. They are probably superior short-term, but when we talk about long-term, so 1 year and beyond, and really long-term is all that matters for our patients, right? You need to maintain your weight loss. It doesn't matter if you lose weight for 3 to 6 months, right? You need to keep the weight off to actually have that cardiometabolic and morbidity benefit that we're striving for. So for 1 year or beyond, there have been numerous meta-analyses comparing different macronutrient contents. And the only thing that ever has actually been shown to be beneficial is adherence to diet and caloric restriction. That predicts weight loss after 1 year. This includes intermittent fasting when they control for caloric intake compared to, diet therapy. When whatever it may be, calories are kind of the end all be all. So however your patient wants to get to a calorie deficit, whatever foods they like to eat, that's the most important diet plan to have them on. The thing that they can stick with, that they like for the long haul. So macronutrient content doesn't really matter. Obviously, you don't want to tell your diabetic patients to go on a high carb diet. That might be counterintuitive. And if somebody has specific medical needs, right, like high cholesterol, you might be focusing your diet on a high fiber, low fat diet. But I'm just talking about generally for weight loss. For weight loss, calories are the end all be all. And this needs to be individualized and reassessed on an ongoing basis, depending on how someone's progressing. So general recommendations for weight loss, again, macronutrient distribution should be individualized based on taste preferences, cultural beliefs, food availability, affordability, and then metabolic goals. But in general, we're targeting an energy deficit of about 500 to 750 calories a day. So in women, on average, this works out to be about a 1,200 to 1,500 kilocalorie a day diet. And for men, it's about 1,500 to 1,800. So if your patients are asking for calorie recommendations, that's a good place to start if they're, average in the 30 to 40 BMI. You want to always tell your patients to avoid high-calorie beverages. That's often a sinkhole for a lot of patients. And then you want to encourage healthy eating patterns like the DASH diet, Mediterranean diet, low-fat, American Heart Association, or plant-based diets. And the thing I really harp on with a lot of my patients is ultra-processed foods. We really want to start avoiding these whenever possible. And so ultra-processed foods are associated with higher caloric intake, strongly associated with weight gain, greater BMI increase over time, increased all-cause mortality, and lower age and lower socioeconomic status. So, right, our kids are being targeted with marketing, particularly kids that might be in different socioeconomic demographics are not always having awesome access to food. And so we want to prioritize, just educating our patients that some of these things are just very deleterious for our health. So you can see my illustration over here on the left, but, Apple Jacks does not actually have any food products. So when we say ultra processed, we mean that there's food derivatives of things that they're so processed that it's essentially a whole bunch of chemicals. If you look at the list, I think there's like 23 ingredients, right? And the same thing, chicken nuggets are not even chicken. It's not whole chicken, it's processed chicken that has like filler and breading and all sorts of stuff in there. And then there's breading on the outside. So we're eating a lot of foods in our diet as a whole. And if you look at the trends in weight, it's really the 1970s that obesity started to skyrocket. And one of the big things, obviously there's many different environmental factors, but one of the big things that changed was industrialization of food really took off. At that point, we had TV dinners, we had a lot more supermarkets carrying things. And if you look at how many products were available in the supermarket back in the 70s versus now, it's increased astronomically. So these foods are not great for our body. Obviously, there are times where we can't avoid eating them, but you do want to encourage your patients to minimize them. And then physical activity. So one thing is, it's not necessarily something that we need to push for weight loss. Physical activity is really important for weight loss maintenance. But all of our patients, we want to be encouraging cardiovascular exercise for heart health and fitness. And so the recommendation, if you look at, the American College of Sports Medicine's guidelines, they recommend 150 minutes a week or more of moderate aerobic exercise spread out about 3 to 5 days a week. And they recommend doing resistance exercise about 2 to 3 times per week. And the goal is to increase energy expenditure, mobility, help prevent weight regain. Depending on your patient, you might need to assess them before starting an exercise regimen if there's any concern for cardiovascular disease. And ultimately, you want to set goals with your patient based on their baseline level of fitness, age, and preferences. You don't want somebody going from doing nothing to trying to run a marathon. They're going to get injured, and that becomes counterproductive. And so when we look at expected initial weight loss with different modalities of exercise, it's really limited, right? So again, we want to be recommending these things to our patients, but I also want to make sure we're clear with our patients that this isn't going to be like this huge boom or bust. On average, initial weight loss is somewhere in the order of 0 to 2 kilograms of weight loss. When we combine this with caloric restriction, we certainly see accelerated weight loss. But in general, the exercise itself is not doing a huge thing. And muscle mass is the biggest driver of our appetite and our metabolic rate. So as you exercise more and build more muscle mass, that can drive appetite. So again, it's helpful to keep metabolic rate up on the back end after someone's weight reduced, but doing it isn't going to make or break a weight loss effort. It's really the diet and the caloric restriction that becomes the most important thing. And so let's move on to pharmacotherapy. So first thing is to avoid weight promoting medications, before we talk about obesity pharmacotherapy. There are many agents that we prescribe to our patients that are associated with weight gain, including diabetes medications, hormonal contraceptives, neuropathic agents, antipsychotic medications, steroid, beta blockers, certain antidepressants and certain sleep agents. And again, obviously, we have to use these things for many of our patients who are symptomatic in other ways. But in thinking about, managing them, if there are ways to switch to more weight neutral therapies or to minimize dosing, ideally, you can optimize the amount of weight that they might gain on those particular therapies. And then the next step would be to consider anti-obesity pharmacotherapy. So we said, body mass index of 27 or greater with an obesity-related disease, or body mass index of 30 or greater, or potentially lower if somebody has Asian ancestry. And then you want to, assess whether somebody has either tried and failed lifestyle modification already, or in thinking about, their overarching targets for weight loss, whether lifestyle alone, remember that 1 to 8%, whether that's going to be enough to actually achieve their weight loss targets. And so if not, you want to early intervene with medical therapy. You also want to consider medical therapy for patients who've regained after prior successful intervention, and that can include after bariatric surgery. Want to consider whether there's any medical contraindications. And then the final piece, and this is probably the most important piece, is will the medication be affordable? And so for Medicare and Medicaid, these are excluded from coverage in both DC and Maryland, where most of us practice. There's some limited coverage in Virginia. And as far as private payers, about 1 in 3 insurers will actually reimburse for obesity coverage. So even when somebody has great insurance, they still may not have access to these medications, and they're cost prohibitive for most patients. So I just want to summarize the FDA approved options for anti-obesity medications. The ones on the left are all FDA approved for long-term use, and the ones on the right are not. So first group of medications are going to be appetite suppressants or anorexics. This includes Qsymia, which is a combination of phentermine and topiramate. And then Contrave, which is a combination of naltrexone and bupropion. You may be familiar with these meds for other indications, but they have an appetite suppressing effect together. Probably most of you are familiar with the GLP-1 receptor agonist. So liraglutide, when we use it for weight management, is called Saxenda. It has a different name called Victoza when we use it for diabetes. And then semaglutide is Wegovy. Again, we might know this as Ozempic if you prescribe it for diabetic patients. We have a combination GIP and GLP-1 receptor agonist. It's called tirzepatide. When we use it for weight management, it's called Zepbound. For diabetes, it's called Mounjaro. And again, these drugs are not interchangeable. They are technically the same medication. They are in different pens. And from an insurance standpoint, they are not the same medication. They have different FDA indications. And so you have to be sure you're prescribing your patient, if they don't have diabetes, the right drug. So just wanted to be clear on that. We have a fat calorie malabsorption agent that's been around forever. Most patients do not like this. This causes diarrhea and bloating and fat malabsorption. So not a hugely popular option, especially because it doesn't cause that much weight loss, but it is approved for long-term use in patients as young as 12. And most of the agents actually over here are approved for patients who are 12 and older. So I don't know if any of you are med peds in the room, but those become options for our patients as well. And then we have CNS stimulants, which are really only meant to be used for 3 months or less. We have setmelanotide, which is a MC4R agonist. That's specifically approved for genetic forms of obesity in our leptin-melanocortin axis that regulates appetite. And then finally, there's a mechanical hydrogel called Plenity, which kind of blows up in your stomach and fills up space, and then you wind up going to the bathroom. It's not available through retail pharmacies. So that's not really something we routinely prescribe, but it is available in case you need a second-line option for your patients. And so comparing efficacy of the weight loss meds, so you can see, most of the agents that we had prior to, 2020 were not that effective. We really didn't have anything. Qsymia was kind of our star of the show, and it maxed out around 8.5% weight loss. And so it wasn't until recently, with the introduction of GLP-1 based therapies, that we actually have drugs that are starting to approach and above that 10% threshold that we need to hit, right? Tirzepatide, and this slide is from a year ago. I should have updated it. We have extension data, which I'll show you in a couple slides, but tirzepatide at 88 weeks causes even more weight loss than this. But at 72 weeks, it's causing about 21% weight loss. So this is really dramatic, right? This is approaching bariatric surgery. And now we actually have effective meds that we can treat our patients with. The hardest part is actually getting them for the patients. And then I just wanted to mention that in development, there are multiple different agents out there right now that are being tested, oral GLP-1s, alternatives, a few triple agonists, which are not only GIP and GLP-1, like tirzepatide, they are also agonists to glucagon receptors. And so they just published some of the phase 2b data from retatrutide, and it's really exciting because this drug is causing about 26% weight loss. And like 75% of people who take this drug were losing over 15%. So we're starting to see really, really amazing numbers. We're starting to see near, bariatric surgery level disease remission. So I think the next 5-10 years as you go out into practice are going to be really exciting, and you're going to have some more options for actually treating our patients. So just to compare some of those different drugs we just mentioned, so topiramate and phentermine, the topiramate component, again, you may have used this for migraines or seizures, but this is a GABA agonist, and it works together with the phentermine component to potentiate it. Phentermine is a stimulant to our CNS, and so it increases brain norepinephrine and dopamine, and this helps kind of that reward pathway. It helps with inhibitory control and helps suppress appetite. And on top of that, it's a sympathomimetic, so it helps kind of boost metabolic rate. So that's our mechanism there. It's an oral drug if your patients are not excited about an injection, and it does have a proven A1C lowering benefit. Some side effects include stimulant effects. It's teratogenic, so any women of childbearing age thinking about taking this medication need pregnancy tests before they start, and then routinely throughout, and need to be using reliable forms of contraception. And it can increase risk for metabolic acidosis and kidney stones. It does interact with some drugs, and it's fairly expensive when there's no coverage, to the tune of about $300, $400 a month. But a lot of the insurances are going towards these older, less effective therapies for coverage. So I'm actually finding that it's easier to get Qsymia approved now than it had been, say, 2-3 years ago. GLP-1 agonists we'll talk about in another slide, same thing with tirzepatide. But the one thing that sets these apart is, again, the amount of weight loss, right? They're much more robust than these other agents, and they have established major cardiovascular lowering benefit in addition to A1C lowering. So we have cardiovascular outcomes trials from both of these drugs, and they are improving morbidity and cardiovascular outcomes for our patients. So there's this, again, we finally have therapies that are effective. I think it's really exciting. Orlistat, we talked about, that's our fat malabsorbing agent. This is non-systemic. It doesn't really interact with other meds. However, it causes horrible GI issues, can increase risk for liver failure and gallstones, and fat-soluble vitamin deficiency. So this should really be like a last resort option. Don't use it in anyone on anti-epileptics or Coumadin due to med interactions. Can also interact with levothyroxine. And then finally, Contrave, the combination of naltrexone and bupropion. So the naltrexone is a mu-opioid antagonist. Our bupropion is going to increase central norepinephrine and dopamine, again, similar to phentermine. But the stimulation that happens from those neurotransmitters gets downregulated. And so the mu-opioid agonist actually helps kind of bypass that. It helps keep the brain still responding to that appetite suppressing pathway. So it's helpful. Bupropion is also helpful for addiction, right? We prescribe it for, mood issues and for smoking cessation. So folks who are kind of bingers and cravers and are describing kind of food addiction, this therapy works a little bit better for them versus other options. Can impact mood, can cause dizziness and headaches, and want to be careful, with opioids and pain medication, because the naltrexone obviously will counteract that. So when I talk about our effective therapies, so GLP-1 agonists, they work by delaying gastric emptying. So this is a hormone. Normally, GLP-1 is secreted by our small intestine when food is present to tell the rest of the body, hey, we have food. Like, hey, brain, stop eating. We don't need any more food. Hey, liver and pancreas, we got food coming in. So it helps with glucose-dependent insulin secretion. It helps slow down digestion. And it also helps enhance satiety directly in the hypothalamus by acting on, POMC is our appetite suppressing pathway. So helps activate that. Our two therapies are liraglutide and semaglutide. Liraglutide is a once daily into the skin injection, requires a little needle tip, and you'll titrate that every 1 to 2 weeks, as described here. Semaglutide, in the form of Wegovy for weight management, is an auto-injector pen, which you can see up in the top corner of the slide. That starts at a dose of 0.25 milligrams into the skin, and then that gets titrated every 4 weeks because it's a little bit slower acting, up to a maximum of 2.4 milligrams. Our GLP-1s have an established weight loss benefit, cardiorenal protective effect, and again, lower MACE. There's a really nice established A1C lowering benefit with these of about 1.1 to 2.1%. There's a concern for medullary thyroid cancer, and we wouldn't use this in anybody who has a history of MEN syndrome because we have a lot of receptors on our C cells and the thyroid for GLP-1. But outside of that, Only other contraindication would be a history of pancreatitis or active, pancreatic disease. Potential side effects include nausea, vomiting, diarrhea, tachycardia, and then rare side effects include pancreatitis, gallstones. And then there are some reports about mood issues and suicidal ideation. They just put out a kind of a meta-analysis looking at this, but there have been over 200 reports around the globe about some suicidal ideation associated with the medication. In larger pooled studies, there hasn't been a significant association, but just putting that out because that's obviously a very severe side effect, just in case your patients report any mood change on these drugs. And so wanted to touch on the step 1 trial. So this is the semaglutide efficacy for people with obesity trial, and it shows robust weight loss at 68 weeks. So the folks in this trial had an average BMI of 38 at baseline. They started with a weight of 105 kilograms. They were not diabetic, but about 40% up to had pre-diabetes at baseline. So this is a study of about 2,000 individuals. And what I wanted to point out is when we do these weight loss trials, they're not in isolation. The placebo group is also getting lifestyle interventions, right? This is kind of universally true. And so it's important when you're looking at these to see, well, what was done? Because sometimes in the real world, or when you're prescribing these for your patients, you may not get the same effect as they got in this trial where they were having really nice kind of high intensity lifestyle modification happening. But over here on the left, we see body weight change from start of the study. So you can see this is really, really nice decline over here to about a 16% weight loss at 68 weeks. But we have to compare to placebo. So the placebo group was also getting this lifestyle intervention, which included 150 minutes a week of exercise. So remember, I told you that was our goal recommended by our sports medicine colleagues, a 500 calorie a day deficit. And they also had coaching and were routinely checking in with study investigators, and they were self-monitoring every day with a journal. So, much more than sometimes we're able to get our patients to do in a real world trial. But relative to placebo, there was still an added benefit of medication, almost 12.5% greater. So highly, highly effective therapy. And then when we're looking at these drugs, we want to also see who is hitting that target. How many of our patients are hitting that magic number, right, of 10% or 15%. And so if you look over on the right, you can see compared to placebo, we have, 75% of individuals who take this drug through this time window were able to achieve a 10% weight loss or greater, and over 50% actually hit 15%. So this is really highly effective therapy. And I'm personally very excited that we have these options now to give to our patients. So just to kind of highlight over here, and at 20%, there was still about 35% of people. So again, that's comparable now to bariatric surgery. And I also wanted to mention the step 2 trial. So this is same kind of thing, looking at max dose semaglutide, but this study was done in diabetics. The original study I just showed you, remember, was 40% pre-diabetics, and then everybody else had normal glycemic parameters. So same intervention, 150 minutes a week, negative 500 calorie intervention. They were also looking at different doses. And again, not quite as effective. And so this is getting back to that primary versus secondary prevention, right? We want to intervene early. Our diabetics don't respond as robustly to these drugs when we add it after diabetes has already been established. They're already higher risk, but still effective. But when you compare to step 1, and you look at the 15% weight loss rate, it's about half as many people who have diabetes who are losing those targets. So again, catch your patients early, be more aggressive about prescribing these medications before somebody gets to diabetes. Regardless, this is still nice, highly effective therapy. About 45% of people hit that 10% number. But the problem with these therapies, and I get this question a lot in clinic, right, is what happens if I stop this medicine, or what happens if I can't get it? Because there's national back orders everywhere, right? And so we have data from both the step 1 extension trial and from step 4 extension trial. So the step 1 trial I just showed you, right? So this is that 68-week data. They did an extension phase and they followed people off of therapy, right? And so placebo, it also gained a little bit of weight back. They weren't doing that supervised high intensity lifestyle modification anymore. But you can see that the folks who went off drug also regained almost all of the weight, right? It's about 60% to 70% on average within a year of going off of treatment. And the same thing over here in step 4, right? So this didn't just stop people. They took the group, and some people switched to placebo after 20 weeks. And then some folks continued on therapy. And so you could see the continue on therapy kept downtrending really nicely. And the folks who switched to placebo, again, regained most of the weight lost. And it's pretty quick. So again, some of it has to do with the how much you lost, but effectively those folks are almost back to where they started a year later. So we need to get insurers on board. But again, obesity as a chronic disease has to be managed that way. We really need chronic therapy for these folks. And then our second highly effective therapy, tirzepatide. Again, we get all the benefits of our GLP-1, but we also see some effects from that GIP component, which helps enhance lipolysis, so kind of energy mobilization, through glucagon, and it also enhances satiety separately. So you can see our titration dosing, again, A1C benefit, and very similar side effect profile to our semaglutide. So the SURMOUNT-1 trial proved again that tirzepatide was highly effective for weight loss. Really similar stats to our folks who were in the STEP 1 trial. So average BMI about 38, weight 105, about 40% pre-diabetics, and this was about 2,500 patients. And so you can see at the highest dose at 72 weeks, we have over 20% weight loss now with tirzepatide 15. So really astounding. And if you think about the numbers I just showed you from the STEP trial, so now we're hitting 10% weight loss, about 75% of patients. 15% weight loss, we're upwards at the highest dose, about 70%, right? 20% weight loss, now we're about 50%, 55%. And 25% weight loss, now we're actually having over 30% of patients achieving 25% weight loss. We are at bariatric surgery level weight loss, right? So this is super exciting. And I wanted to show you SURMOUNT-4. So we did an extension trial looking at what happens if you go beyond that 60 or the 36 weeks, excuse me. And patients continued to lose weight. So that number quoted 20%, right? But if you actually keep people on therapy, the nadir happens somewhere between 76 and 88 weeks, and they lost an additional 5.5%. So they maxed out at about 25% out, beyond a year. And then you can see the folks who got switched to placebo continued to steadily gain. At a year out and the extension arm, they still were weight reduced relative to where they started, right? So they're still almost 10% down from their baseline weight. However, I don't know what would happen if we extend that trajectory, right? They regained about 14% of their weight on average from the time they stopped therapy. And relative to the folks who kept on medicine, right, that's like 19% difference? So you can see, again, you have to be on these therapies long-term, and there's a high risk for weight regain off of them. So how do we select therapy for our patients? You really want to optimize risk-benefit ratio, think about coverage, think about med safety, contraindications, and the like. And I just want to highlight one study from Mayo, which showed that phenotyping our patients to kind of think about, where their issue might be really actually helped improve weight loss outcomes. So they kind of grouped people into 4 categories. Hungry brain is that, people don't have good central satiety, and they put those folks on phentermine and topiramate. Hungry gut, so those folks had abnormal postprandial. They didn't have a good, release of GLP-1 or GIP endogenously. They got GLP-1 agonists. Hedonic eating is the people with emotional appetite, food cravings. They got contrary to the bupropion and naltrexone. And then slow burn was the people who were felt to have low energy expenditure, and they got put on stimulants. And so this actually resulted in almost 2 times greater weight loss at 1 year when people were matched and kind of, quote, phenotyped to what type of issue that they had. So again, just want to stress, talk to your patients, try to assess, where their issue lies when you go through that interview process with them to try to see if you can match them up to therapy. And then ultimately, you want to make sure patients are on effective therapy. If at 3 months, somebody hasn't been hitting weight loss targets of about 5%, you want to reassess and potentially consider discontinuing and or switching them to a different medicine, or potentially even referring them for bariatric surgery. So just to summarize, obesity diagnostic tools are helpful for screening, but they require clinical validation and interpretation based on individual patient factors. At BMI of 35 or under, waist circumference is actually the strongest predictor of cardiometabolic risk. So get out that tape measure. Weight loss as little as 3 to 5% can be beneficial, but typically 10% or more is really needed for major risk reduction and secondary prevention of disease. There's no single diet that's superior for weight loss. It's really adherence and caloric restriction that are predictors of success. And finally, you should consider obesity pharmacotherapy in any high-risk patients with a BMI above 27 or potentially 23 to 5 in our Asian patients, and then surgery in patients with a body mass index of 35 or greater. And I'll stop there. Thank you.